We will now be examining the ear, nose, and sinuses. Wide peep and vital signs have already been done. The instruments for this examination are 1. Pen light, 2. Otoscope and disposable specula, 3. Tuning fork of 512 kilohertz, nasal speculum, head mirror with a light source, and endoscope. The last 3 instruments are not used in this lab. The patient is to be examined in the sitting position. Infants are examined with the mother holding them in her lap. The examiner should preferentially also be seated. The examiner can also stand. The techniques of examining the ear, nose, and sinuses are inspection, palpation, and performance of added tests. External ear, or auricle and pinna, and surrounding areas. The auricle is a horn-shaped structure which converges onto the external auditory meatus. The color is similar to the color of the skin of the face. It is firm in consistency, mobile, and without nodes or swelling. If folded forwards, it should readily recoil to its usual position on release. Inspection. Inspect the borders, lateral and medial surfaces, and surrounding areas for size and shape. Microtia, a term used for abnormalities of the ear development. Symmetry of size, shape, and position. And both ears should look alike and be at the same level. Position. A line drawn between the outer canthus of the eye and the most prominent protuberance of the occiput should touch the top of the auricle or just below it. If another line is drawn perpendicular to the first one, just anterior to the auricle, the ears should lie in a vertical plane or no more than a 10-degree variation. Swellings and lesions. Small whitish nodules located along the rim of the auricle could be tophi due to deposition of uric acid crystals. These may represent a manifestation of gout. Sebaceous cysts are common on the auricle. They appear as elevations with a punctum indicating a blocked sebaceous gland. Basal cell carcinoma can be noticed in the earlobe. Periauricular pits are commonly seen in front of the ears. Preauricular tags can also be seen. The lobule is the usual site to pierce for earrings. In the Afro-American Caribbean people, these pierced sites are often transformed into keloids, especially on the posterior surface. Lifting of the ear can indicate parotid gland enlargement. This is when the ears are protruding outwards. Part of the parotid gland lies inferior and anterior to the ear. Color. The auricle should have the same color as the skin of the face. Abnormal color includes bluish due to cyanosis, pallor, or excessive redness. And frostbite can also cause pallor. Palpation. For masses or swellings or nodules. Palpate any nodules or swellings previously seen on inspection. Palpate the preauricular and postauricular areas for lymph nodes with the fingertips of both hands simultaneously in a rotating motion and pressing against bone at the same time. Assess the characteristics of any palpable lymph nodes for size, tenderness, consistency, mobility, and distinctiveness of borders. Tenderness may indicate an inflammatory process. Press the tragus against the external ear or pull the external ear up and down. If pain is elicited, an infection of the external auditory canal may be present. Press over the mastoid process. If pain is elicited, a middle ear infection or mastoiditis is likely. Swelling, tenderness, and redness may indicate a polychondritis. External auditory canal. The outer portion is cartilaginous and bears hair. The inner portion is bony and sensitive. Wax secreted by ceruminous glands is often present in the canal and varies from colorless and semi-liquid freshly secreted wax to yellow, brown, or black and hard, usually old wax. There should be no redness, swelling, tenderness, discharge, or scaliness. There should be no foreign body. Inspect for discharge and odor. A purulent, foul-smelling discharge is associated with otitis externa or otitis media with a perforated eardrum. A foreign body in the canal can also give the same signs. A bloody or serous discharge in the presence of head trauma may indicate a basilar skull fracture. Patency. Blockage may be due to wax, foreign body, or swelling. Excessive wax may prevent visualization of the tympanic membrane. Color. Redness may be a sign of infection or recent trauma. Dry, scaly appearance may indicate eczema. Otoscopic examination. Procedure. Tilt the head to the opposite side of the ear to be examined. Straighten the auditory canal by pulling the external ear up, out, and backwards. Attach a disposable speculum, the largest that can be easily accommodated in the ear canal, to the otoscope and insert the speculum of the illuminated otoscope into the ear canal under direct vision. Hold the otoscope like a pen with the index finger and thumb resting the remaining extended fingers against the scalp to prevent sudden deep penetration of the speculum, which can damage the tympanic membrane. Observe the canal for dry, flaky skin or eczema, redness and swelling, the signs of inflammation, masses, excessive wax, foreign body, and discharge. Otitis externa or interna. Visualize the tympanic membrane. The tympanic membrane is ovoid, semi-transparent, and pearly gray in color. There is some mobility of the membrane on carrying out the Valsalva maneuver. Take a deep breath in, then with the lips together and the nares closed by pinching with the thumb and index finger, attempt to breathe out forcefully. Observe for the following: normal landmarks, short process and long process or handle of the malleus, umbo, and cone of light. The pars tensor occupies the lower 4/5 of the membrane, and the pars flexida occupies the upper 1/5. The two parts are separated by anterior and posterior folds. The short process protrudes forwards into the external canal. The handle is located in about the middle of the pars tensor and extends downwards and backwards. The umbo marks the central attachment of the tympanic membrane to the malleus. From the umbo, the cone of light extends downwards and forwards. Color. Diseased tympanic membrane may be dull, yellow, or red. Redness may indicate inflammation or otitis media or recent trauma. Blurring and dullness of the tympanic membrane. Distortion of normal landmarks. Contour, whether the membrane is bulging or retracted. Mobility on the Valsalva maneuver. Fluid level behind the eardrum, and integrity to rule out a perforated tympanic membrane. Lesions such as plaques on the tympanic membrane. Additional examination or hearing tests. The whisper test. Block the right ear by pressing against the tragus, against the external auditory meatus using the index finger of the patient or examiner. Place one hand of the examiner between the examiner's mouth and the patient's field of vision. Stand at the side of the patient about 1 foot away and in line with the left ear. Whisper 1 or 2 words and ask the patient to repeat what was said. Move closer if the patient did not hear what was said until the patient can repeat the whispered words. A distance closer than 1 foot may indicate a hearing deficit. Repeat the procedure on the other side by blocking the left ear and whispering in the right ear. The Weber test. This is useful when hearing loss is asymmetric. Weber tests hearing ability by bone conduction in both ears. Hold a 512 Hertz or high frequency metal tuning fork by the stem with one hand and set the tuning fork vibrating by forcibly pinching the prongs of the tuning fork with the fingers of the other hand and then pulling the hand away while trying to maintain the grip. Place the stem of the vibrating fork firmly on the midline of the forehead or vertex of the skull. Ask the patient to indicate where the vibrations are perceived. They should be centrally perceived or heard in both ears equally. Lateralization to one side or the other is abnormal. Rinne test. Rinne's test compares ear conduction to bone conduction. Each ear is tested separately. Hold the tuning fork and set it vibrating as above. Place the vibrating tuning fork firmly on the mastoid process of one side. Ask the patient to inform you of the moment that he/she can no longer hear the sound. Immediately place the still vibrating tuning fork just outside of the ear in line with the external auditory meatus. There should be no contact between the ear and the tuning fork. The tuning fork should be facing broadside forward. Make a note of the time that the vibration is no longer felt over the mastoid and the time that all vibrations ceased of the ear. The first time represents the duration of bone conduction and the second time represents the duration of ear conduction. The test is repeated with the other ear. Please note that the Rinne test cannot be interpreted in reference to hearing loss without an accompanying Weber test. Additional examinations. Testing for balance. The Romberg test. The patient stands upright with feet parallel and close together and the eyes closed. The patient folds his arms in front of his chest. Have the patient walk in a straight line. Examination of the nose. Examination in both frontal and lateral plane. The nose bridge is normally straight in both planes and the columella and nasal septum should be straight. Observe for discolorations with unusual length, distortions, deformities which can be congenital, deformities which can be acquired, scars, dilated vessels, swellings, and ulcerations. Palpate for tenderness, depressions, crepitus, deformity, and deviations. Examination of the internal nose or nasal cavity. Examination of the vestibule. The shape should be symmetrical and the septum should be midline. There should be no swellings, excoriations, or discharge. Have the patient bend his or her head backwards slightly. Using the left hand, elevate the tip of the nose with the thumb, the remaining fingers being placed in the scalp near the hairline for counter pressure. Using a pen light, observe for deviation of the septum, foreign body, swellings, ulcerations, and excoriation. Test for patency of the nasal passage. Occlude the left nostril and have the patient sniff with the right nostril. Repeat with the patient occluding the right nostril and sniffing through the left nostril. Palpate for the presence or absence of cartilage in the nasal septum. Speculum examination using a nasal speculum or large, clean oral speculum attached to an otoscope. The otoscope is held upside down, the head of the otoscope pointing towards the floor. Using the left hand, hold the handle of the otoscope with the thumb and index fingers. The thumb is on the outside and the index finger on the inside together with the remaining fingers. The remaining fingers are flexed and will be placed in the patient's face to avoid too deep a penetration of the speculum, thus avoiding injury. It is acceptable to hold the otoscope with the head pointed in a cephalad direction, with everything else being the same. The axis of the anterior nares is upward and backwards, and that of the posterior nares is backwards. Have the patient tilt the head slightly backwards. Tip the patient's chin up or elevate the tip of the nose. The speculum is introduced in an upward and backward direction under direct visualization. Avoid touching the nasal septum. The floor, lateral, and medial walls are systematically examined. Each nasal cavity is examined in the same manner. The normal nasal mucosa is reddish, moist, and slippery, without retention of secretions in the floor of the nose or in the area of the nasal meatus. Observe the medial wall. Bend the head slightly forward to observe the anterior and inferior part of the septum, and backwards to examine the superior and posterior parts of the septum. Observe for increased vascularity and vessel fragility. Note the presence of bleeding. Presence of spurs, deviations, or perforation. Note the degree and location of any deviation. Observe the lateral wall for color, size, and quality of mucosal lining. Look for discharge. Note the amount, color, and consistency of any discharge. Observe the conchae. To visualize the middle concha, tilt the patient's head upwards and backwards at an angle of 45 degrees. This maneuver brings it into clear view. Observe for the presence of polyps or neoplasm. Olfactory function of the nose. This is done after testing for patency of the nasal passages. Test each nostril separately. Have available 2 to 3 vials of familiar volatile aromatic odors. Avoid irritating odors. Have the patient close his or her eyes and occlude one nostril. Place the odor near but not touching the nares. The patient then takes a deep breath in the open nostril. Ask the patient to identify or describe the odor. Examination of the sinuses. The normal sinus is asymptomatic with no overlying swelling and non-tender. Transillumination can be clearly demonstrated. Inspect for swelling and redness, nasal congestion, purulent or mucopurulent rhinorrhea. Palpate to elicit tenderness over the maxillary and frontal sinuses. To elicit tenderness of the frontal sinus, apply upward pressure with the thumb in the area of the medial supraorbital ridge. To test tenderness of the maxillary sinus, apply pressure with the thumb over the sinus just above the canine fossa. At times, tenderness over the anterior ethmoidal sinuses may be elicited by thumb pressure over the inner wall of the orbit in proximity with the nose. Transillumination test. It is best to perform transillumination in a dark room. Place a light source just above the upper end of the nasolabial fold, lateral to the nose and inferior to the medial part of the eye. Press the pen light against the bone and direct the light in a downward direction. Ask the patient to tilt the head back, close the eyes, and open his or her mouth. Observe for a pink glow coming through the mucosa of the hard palate. Frontal sinuses. Place a light source just inside the area of the medial part of the supraorbital ridge. Place the border of one hand across the forehead in line just above the supraorbital ridges. Press the light source against the bone and direct the light upwards. Observe a pink glow through the skin in the area of the respective sinus, cephalad to the positioned hand. And that completes the examination of the ear, nose, and sinuses.